Good morning, all. Thank you, Sheikh. Thank you for your warm welcome and introduction. I hope my voice is clear for everyone. Thank you. Let me introduce myself. Those who don't know me, my name is Kiran Kondisetti. I'm working as an RCM director in one of the reputed facility in Abu Dhabi. And as Sheikh said, I have been having 16 years of experience in revenue cycle. Myself a certified coder, CPC and COC, and also I'm a CDIP certified holder as well. Before starting, I'm immensely grateful to all your presence here today, and I look forward for an engaging session. And if you have any questions or queries, please park your questions please reserve your questions at the end of the session, so that we can have an effective discussion. And it is today's topic. What we are going to discuss is our journey from 2018 CPT codes to 2021 CPT codes. This is a broad topic and also might be boring for many people. So it is very important and relevant to know the changes happening in 2018 to 2021, because as you know, across UAE currently we have been moved from 2018 to 2021 effective Jan 2024. So it is very much essential for us to know the updates, what happened in between, and what are the latest CPT codes which we need to use, and their guidelines as well. I'm not going to touch anything related to E&M because this topic is already taken in one of the AABC session recently. But I'm going to explain you about the CPT codes changes. What happened from 2018 to 2021. Please bear with me. Please be patient. And I know this topic is a very lengthy subject, and it might we all need your patience to listen. It could be a great educational session. I'm sure for that. So let's start. So before starting,
Yes.
Yeah, Sheikh, you can mute this mic and all, so that we can. So before starting to the presentation, I would like to give a disclaimer, about the CPT codes. The CPT has been licensed from AMA. So whatever the topic, whatever the presentation which I am showing here, the sole rights belongs to AMA, and I'm just picking up the codes and I'm updating you with the topic. Believe me, I'm not an expert in a complete coding cycle. There might be some human errors might be there in the presentation. If there is any such errors, feel free to correct me. If I'm wrong, I'm happy to correct it. And likewise, if there is any concerns or questions, please reserve it at the end of the session. So we will start now with 2018 to 2019 CPT code updates. So what happened from 2018 to 2019? So if you can see the summary of 2019 CPT codes, we have 335 CPT code changes has been happened. So out of these 335 code changes, I have been break down the details into different categories like E&M, surgery, radiology, laboratory, and medicine. Even we have some changes in category 3 codes. I think someone muted. Someone muted me. Okay, thank you. So if you can see the summary in 2019, we can recognize 335 CPT code change. It's in slide mode only, no? Let me see. It's a slideshow for me. Okay, because it's a slideshow for me. It is showing a slideshow. Let me check again. Yeah, it's in Windows actually. Yeah. It's okay now? Okay. So when these are the changes which we can see. There are 335 changes happened, and I have been given the breakdown details for each and every category. As I said earlier, I'm not going to discuss about the E&M codes because E&M changes is already being taken care of earlier. If there is any further queries on E&M, feel free to ask me in a separate platform so that I know I can answer your questions. Let's go to surgery now. In surgery changes, we have 34 new codes and 6 revised codes and 20 deleted codes. Out of which the breakdown comes like this. If you can see in general surgery, integumentary, musculoskeletal, cardiovascular. So there are various areas, various organ systems. We have noticed some changes. The major changes happened in cardiovascular, and next to that, in general surgery, we have seen some updates on biopsy codes. Let's drill down now. If you can see the first update which we can notice is the FNA. This is one of the important and frequently happening procedure in many facilities, especially by general surgeons or endocrinologists, clinicians. They used to do this biopsies. So previously we have FNA. We have two ports, 10021 and 22. Now this 22 has been deleted and it has been replaced with a different set of codes based on the guidance. For US guidance, for fluoroscopic guidance, for CT guidance, for MR guidance, we have different set of categories of this, different set of code sets also there. And the most important thing which there is an update on the lesion. Based on the lesion, the CPT code varies. So when a doctor is doing a lesion, a biopsy from more than one lesion, each additional lesion can be coded separately. So this is one of the important topic. If the lesion is partially, let's suppose if the doctor is taking a biopsy sample and the biopsy sample is not completely taken out, and if it needs an additional sample to be taken, then please do not consider it as an additional lesion, because it's the same lesion. The doctor is taking a new biopsy sample because the sample which was being taken earlier was not adequate. Okay, that is one of the important update in biopsy. And please note the changes and please inform your concerned clinicians about these changes. Next comes the integumentary system. We can see some updates on the biopsies. Especially the biopsy section has been expanded with further details like tangential biopsy, punch biopsy, and incisional biopsy. So there are 3 set of biopsy codes has been added, and you can see the difference. The tangential biopsies, the biopsy sample has been excised tangentially and it has been taken. It can be epidermis or it can be dermis location. It's a partial thickness sample. It's not a complete sample. It's a partial thickness sample. When it comes to punch biopsy, it's what we call it. The procedure itself demonstrates it's a punch. The doctor will sample has been taken. And when it comes to incisional biopsy also the doctor excise partial sample. They will incise the sample and they will excise the sample, and a biopsy sample will be taken. Here you need to understand one thing: in incisional biopsy, sometimes the clinician will mention that no excisional biopsy has been done. If the sample is only, if the procedure is done only for a biopsy sake, you have to bill biopsy only, irrespective of the excision happened. If it is an excision and then a sample has been sent to a biopsy, you should code the excision codes. So we can see we have some regulations in this billing and reporting of these biopsies. So again, here also each separate lesion can be coded separately for each and every type of biopsy which has been taken. I have given some guidelines related to this. So please do not confuse with shave removal, because if you can see the description of tangential skin biopsy, you can see the tangential biopsy of skin. Example: shaving, scooping, saucerizing, curating. So these are the methods, where this biopsy sample will be taken. But if the doctor is doing directly a shave removal, which is something different than the skin biopsy, that no excisional biopsy has been done. If the sample is only, if the procedure is done only for a biopsy sake, you have to bill biopsy only, irrespective of the excision happened. If it is an excision and then a sample has been sent to a biopsy, you should code the excision codes. So we can see we have some regulations in this billing and reporting of these biopsies. So again, here also each separate lesion can be coded separately for each and every type of biopsy which has been taken. I have given some guidelines related to this. So please do not confuse with shave removal, because if you can see the description of tangential skin biopsy, you can see the tangential biopsy of skin. Example: shaving, scooping, saucerizing, curating. So these are the methods, where this biopsy sample will be taken. But if the doctor is doing directly a shave removal, which is something different than the skin biopsy, because here is the removal of completely removal of therapeutic removal of complete lesion, which is happening here. Maybe after the lesion excision, there might be histopathologist sample might be taken, but it should not be considered as tangential biopsy. It should be a shave removal. So always consider the documentation given by the clinician. It is very important and very imperative that you need to explain to the clinician whenever they are doing biopsy. They need to clearly document that the patient, the sample, the excision or the biopsy samples what they are taking is clearly only for the biopsy sake, for the histopathology sake. If they are doing it for therapeutic removal, it should be an excision code should code it instead of biopsy. So during sampling the lesion of for histopathologic evaluation, the entire lesion ends up being removed. The procedure is still considered as a biopsy. As I said before, if it is a biopsy, if it is only for biopsy purposes, even if the entire lesion is removed itself, it should be considered as a biopsy. However, if the doctor is documenting it's an excision and then biopsy, then you should code the excision codes. So the difference you need to consider here. And as the characteristics of excised tissue cannot be used to determine the appropriate coding for the services in these cases, it is incumbent upon the provider to explicitly indicate the intent of the procedure in the medical record. This is very important. This is, I'm stressing again, this is very important. The doctor need to document whether it is for a biopsy or for an excision. Next, code 11104 punch biopsy and code 11106 incisional skin biopsy of a single lesion includes simple closure. So when a simple closure is performed along with this punch and incisional biopsies, it's an integral part and it's a bundle code. You should not code it separately. And add-on code 11103 may be reported with 11104 and 06. So like as I said before, if there is a doctor is performing multiple biopsies, so we can build multiple biopsies based on the initial code. We have to give one initial code, and the remaining codes can be related to other procedures, whatever they are doing. So while add-on code 11105 may be reported in conjunction with 11106, so you can report 11105 punch biopsy additional lesion with incisional biopsy initial code, Likewise, you can when multiple techniques are used to sample multiple or separate additional lesions. So when multiple techniques are used on the same lesion, you should not code multiple techniques together. It should be on a sample which is at different location areas. So you should also make a note that 11107 may only be reported with 11106. So 11107 is nothing but incisional biopsy additional lesion. So you have to code with only with incisional biopsy initial code. You should not code with transitional biopsy or punch biopsy codes. However, the punch biopsy additional lesions can be reported with incisional biopsy principal codes. So this guideline is very important. Please make a note of it. And next comes musculoskeletal CPT codes. In musculoskeletal, there are some updates on graftings, especially these allografts for osteoarticular areas and also mostly in the knee areas and all. So you can see some different kind of graftings. One is osteoarticular and also hemicortical intercalary and intercalary complete. So these codes were not there, were not utilized before, and these are some of the new codes which has been added. These codes will be used mostly in the spine surgeries. So whomever is doing spine surgeries, please make a note of it. These codes might or might not impact your DRGs if there is a DRG. If you are doing it as a day case, you should make a note of it. These codes need to be added as an additional codes. So these codes are usually used as these are allografts, not xenografts or autografts. These are allografts, which has been taken from the self body location. And apart from this, there is one more code has been added, which is nothing but 27369. This is a contrast knee orthography. So before performing any orthography, knee orthography, they will inject this contrast material. So when we are using this, whenever we are doing a knee orthography, please make a note. This injection procedure can be coded separately. So if you make a note of the below description, an injection procedure for knee orthography entails fluoroscopic guidance, injection of contrast, fluoroscopic guidance in the injection of contrast into the intra-articular space for subsequent contrast enhanced evaluation, same like normal CT and MRI, wherever we do a contrast with contrast. It's a joint contrast, which can be coded separately. But do not confuse this code with a normal orthocentesis procedure. Orthocentesis is completely a different subject and different procedure than this knee orthography contrast material. So this code will be replacing the previous code, which is 27370, which is an injection of contrast for knee orthography. So as I said, there are some major updates happened in cardiovascular. So in cardiovascular, we have noticed many changes. Most of the bigger facilities who are having a complex surgeries, they might need this update. They need to know, because who was having a tertiary hospitals, they do this kind of surgeries. So secondary and primary care health cares or hospitals, they don't use these codes. So, but however, I need to update the CPTs. The changes happen. So there are some new codes were implemented in 2019, which is an implantation and removal of leadless cardiac pacemaker. So this leadless cardiac pacemaker is an latest update. In emerging technologies, previously we are using with leads, generators and all. So now we have an updated version, which is called as a leadless cardiac pacemaker. So it has separate ports now, 33274, which is for insertion or replacement, and 33275 is for removal. So these codes were added, and please do not report any 33275 along with 33274, because the initial code itself says insertion or replacement. So when there is when there is a removal and replacement, only code with 33274. And along with this code, you are not supposed to build right heart catheterization is bundled into this code and should not be coded separately as well. So earlier we have category 3 codes for this leadless cardiac pacemakers, because category 3 codes, as you know, this is an emerging technology codes which were available in 2018. Now these codes has been deleted and these were replaced with the CPT codes 33274 and 275. And there are some changes happened, revisions happened in subheadings. Previously we have implantation of patient activated cardiac event recorder was there, and these codes were replaced now with subcutaneous cardiac rhythm monitor. The timely, when there is an update happening in healthcare innovations, automatically the code sets has been replaced accordingly with the new generation. So these codes, patient activated event recorders has been replaced with cardiac rhythm monitor, subcutaneous cardiac rhythm monitor. So we also has here insertion and replacement, which is 33285 and 286. You also make a note of it. The initial insertion includes the programming also. So for subsequent electronic analysis and programming, we have a separate code for that. We have to use those codes, which has been given in the subsection there. There are some additional codes which are wireless pulmonary artery pressure sensoring. This is for long-term hemodynamic monitoring, which is 33289. This code has been added. So and also there is one more code along with this code. We have to utilize. We have to build one more code, which is 93264, which is remote monitoring of pulmonary artery pressure sensor. I will be explaining this in the medicine section. And there is a new code for valve replacement also. So 33440. So 33440 is a new code which is used for the valve replacement. So this code includes components of ROS procedure and Kono procedure, which is being done. So please ensure that the integral inherent components of this. The next comes additional CPT code and add-on code, which is thoracic aortic aneurysm subsection, because it's in the thoracic aortic aneurysm subsection, which is an aortic hemiarch graft. So again, the graft section has been updated. Likewise, what happened in the musculoskeletal system for spine surgeries. So please make a note of it, because it's an aortic graft and it will be used mostly in the major surgeries. So I have given some of the guidelines, for this add-on code. So please make a note of it. And beyond that, there are some changes in PICC line also. So PICC line, if I'm not wrong, this course might be available in the current event also. So previously we have a course 36568, 36569. This course has been does not include image guidance. So now this course are having some updates. So without image guidance and with image guidance, there are some different course sets are there. So 36568 is used for younger than 5 years, and 569 for 5 plus years old. At the same time, with image guidance, we have a different set of codes now, which is 36572 and 573. So please make a note. So if there is imaging guidance, any imaging guidance, we should not load the imaging guidance separately. Now we have a separate code for that. So please make a note of it. And in hematolymphatic and digestive system changes, we have some updates as well. Previously in lymphatic system, we have a code addition, which is 38531, which is open biopsy or excision of inguinal femoral lymph nodes. So this is a unilateral code. This code can be built with quantity 2 or with 50 modifier if it is a bilateral. So these are unilateral codes. So mostly this the biopsy or excision of inguinal femoral node. So mostly we might notice this when there is an inguinal hernia repair or any other deep pelvic area surgeries. And beyond that, there are some changes in digestive system also. So in digestive system, the change of gastrostomy tube, which is percutaneous without endoscopic or endoscopic guidance, which we are using frequently, this code has been deleted, and there are some new codes has been replaced. One is 43760, which is an replacement of gastrostomy tube. With this is without imaging guidance, and 43763 is revision, requiring revision of gastrostomy tube track. So for there is a tip here down below. So for percutaneous replacement of gastrostomy tube under fluoroscopic guidance, we have to use a different set of code, which is 49450. And of course, if it is done through endoscopy, we have to use 43246. So these codes are without whatever the codes which has been updated here are without imaging or endoscopic guidance. So please make a note of it. So these are percutaneous codes. And there are some changes in urinary system also. So this is one. These are the rhythm therapy. This is one of the emerging technology which is being by the urology doctors nowadays. So resection of prostate cancer, transurethral resection of prostate tissue, especially for prostate cancer cases, or apart from that, benign prostate hyperplasia also the doctors use this procedure. So it's very useful now. You can use this code. Earlier we don't have any CPT code where we used to go with the unlisted code for this procedure. So beyond the other CPT codes, we also have this code. So if you can see the difference between 53852 and 53854. So in the both areas, the radio frequency is applied, but in 53582 it's a direct, and 53584 it's an indirect, because the delivery here is through water vapor thermotherapy, radio frequency generated water vapor thermotherapy. Okay, but the procedure, both the procedure are happening through radio frequencies. And apart from that, there are some two additional codes have been updated. It's 50436 and 437. 50436 is dilation of existing tract percutaneous for an urologic procedure, including image guidance. So the urethral tract and all, for dilations and all, we can use this code. And 50437 is including new access into the renal collective system. So these are two additional codes has been added. There is a code has been deleted, which is 50395, which is introduction of guide into renal pelvis or ureter with the dilation of established urostomy tract. So in urology, especially in nephrology section, we have a lot of code sets are there. Apart from cystourethropy, we have many other complex procedures, either percutaneous or open procedures, in which the multiple procedures can be built together along with the major complex procedure. Please always check the documentation while building these procedures. In rhythm therapy, please make a note that there are some expensive supplies which will be used in this procedure. So if the doctors are doing it as a day case, kindly ensure to request a separate approval for that HIPEX. I think that HIPEX cost is greater than 1500 if it is a day case. However, if we are doing this as a DRG, all these supplies might be inclusive, because these supplies which are utilized in rhythm therapy might not be categorized under high cost HIPEX. Next is the neurosurgery changes. In neurosurgery changes also, we have some new codes has been added. Balloon dilatation of intracranial vasospasm. This is percutaneous. Each additional vessel, because the initial code is already there. These codes, there were some revisions happened in terms of previously it was with a family. Now it has been revised with the territory. So you can see the description at the end of the each additional vessel in the same vascular territory. So to give more accurate meaning for the code, the term family has been replaced with territory. And the tense code previously which we are using has been I think deleted now. CPT 64550 application of neurotransmitter was revised in 2018 to include a transcutaneous nerve stimulation unit as an example of transcutaneous electric neurostimulator. However, for 2019, this code has been deleted, So if there is a TENS performed, you have to use the physical therapy codes, which is 97014 for electrical stimulation and 97032 for electrical stimulation requiring constant attendance. So supervision and constant attendance. So there are two codes already available there. There are no changes in these physiotherapy codes except some two additional cognitive cognitive therapy. This tense code has been, which are used by us earlier, has been now deleted. This is also an important update. You need to make a note of it. In 2019, there are some radiology changes also there. So 10 new codes has been added and 6 deleted codes and 4 revisions were happened. Let's see the changes. So there is a code elastography. This is one of important area where most of the gastroenterology clinicians are using. So elastography mostly it is used for liver fibrosis. Apart from liver fibrosis, they are also using for some other clinical indications. So please make a note now that we have a code for magnetic resonance elastography. And also we have a code for microbubble sonography contrast uh, uh, ultrasound, which is used. There are for initial lesion as well as additional lesion. We have a different set of codes. And apart from that, we have a code for ultrasound elastographic parenchyma, which is an organ specific, and first target lesion and additional target lesion, ultrasound elastography. So we have some tips here for elastography. So always Adam code we will use only with the primary code. For sure, it is an common coding guideline. So 76981 we have to use only once per session. So if it is in the same parenchymal origin, so if it is the same parenchymal origin, you have to use only once. And the shear wave liver elastography, there is a difference code. So if the doctors are performing in shear wave liver elastography, you have to use the code 91200. So please do not use any of the elastography codes unless the doctors are clearly mentioning it is in liver elastography. And for evaluation of a parenchymal organ and lesion in the same parenchymal organ, at the same session, you have to use 76981 only once. And do not report 76983 more than 2 times per organ. So even if there are more lesions, you have to use 2 times as an MBB. It's an important update again in MRI section. You have seen you have code changes for MRI breast. We have a unilateral and you have bilateral breast MRI codes. Previous codes has been deleted. 77058 and 59 has been deleted. So there were 4 new codes has been added. So you need to ensure with this update because this is one of the frequent MRI which is being performed. Also, you need to make a note that this code has some price variations also happened in with this update. Previously the prices are different, and in the latest revision, this code prices has been reduced a lot because this is a frequently performed procedure, and the prices are according to the market strategies. And also in the MRI, we have without and with contrast codes also there. Along with computer aided detections. So this computer aided detection, we have earlier a separate CPT code was available. Now as a part of this code, and it can be it cannot be built separately when we are using CAD. So this course has been revised. So you can see the revisions in the highlighted. So for dilation of previously we have a nephrostomy in that dilation of ureter. Now the nephrostomy has been removed. So dilation of ureter or urethra, radiological supervision and interpretation, and that is 74485. And in 77021, MRI imaging guidance for needle placement. Previously, it was MRI guidance for needle placement. Now it has been imaging has been added. So MRI imaging guidance for needle placement, radiological supervision, and interpretation. This imaging, why the imaging has been added? Because please make sure that whenever you are doing a guidance procedure, any needle guidance procedure, you need to secure the images of the guidance. So this is one of the important coding guideline. If payers are approaching, and you need to prove that the services are performed with imaging guidance and the images are secured. So we have a codes for MRI imaging guidance for needle placement as well as MRI imaging guidance for monitoring parenchymal tissue ablation. And also we have some changes in 77387, guidance of localized of target volume for delivery of radiology treatment, where the delivery has been repeatedly documented. So in this update in 2019, the additional delivery has been removed. Okay. So this course has been deleted, as you know, there was some changes in breast ultrasound. So those 589 and 58 and 559 has been removed. And fluoroscopy more than 1 hour has been deleted, 76001. And 0159T, this is an category 3 code, so which is also deleted. And some vitamin B12 absorption studies, these also deleted, 78270 to 78271 and also 78272. Let's go to pathology codes. In pathology codes, there are 95 new codes, 5 deleted codes, and 11 revision codes. Majority of the codes have been updates are happened at PLS. I will also explain what is that. So if you can see the pathology changes, there are new 4 new definitions has been added to the guidelines for the molecular pathology. So DNA methylation analysis, gene expression and promoters. So these revisions has been, the definitions has been added to the guidelines. So Tier 2 codes, 27 gene test moved to Tier 1 codes. So this is one of the important thing. So 6 codes has been revised and 6 new gene test has been updated. So the codes which has been revised, 814 401 403 404 405 and 407 has been revised. And as 27 gene test has been moved from Tier 2 to Tier 1. And beyond that, there are some updates on genomic sequencing. These codes are, we are not using these codes frequently. However, since there was an update, we have to demonstrate this as well. So in genetics testing for we have some codes noted, 81443 for 15 genes, multi genomic sequencing analysis panel, and two additional code has been added as well, which for oncology RNA gene expression. This is for RTP sphere for 11 genes, and also 81596, which is for hepatitis C infection. There are some biochemical assays has been added as well. And as I said, there are major updates happened at PLA codes. PLA codes are proprietary laboratory analysis codes. These codes are alphanumeric codes. These codes were not being utilized in UAE. However, these codes will be used in some of the facilities in US, where these codes are being used by given by the manufacturers or the lab manufacturers, because it's an experimental. These codes are emerging codes. We're still in still performing as an experimental, like if you can say any new inventions has been taken pair, those new inventions, they wanted to trial these, with the samples. So while trialing this laboratory analysis, they use these codes. So these codes currently we are not using. If any of the facility has an option to use, they can use it. And apart from that, we have some code, some other chemistry updates also there. 82642 DHT dihydrotestosterone. This is being used by the urology and fertility clinicians. This is one more update. Previously, we don't have code for this. And the small dense LDL cholesterol, this might be used frequently as well. So since there is an latest updates happening in the market, so apart from LDL, there are many other LDL testings will be doing by the clinicians. So in that, there was new update in small with a small dense LDL cholesterol, which can be built separately apart from the LDL panel if it is indicated. And there are some medicine section codes updates are there in 2019. 25 new codes has been added. Out of these 25 new codes, mostly we can see some neurology and neuromuscular changes happen. And we have 13 codes has been deleted and there are 17 codes has been revised. Let's see in brief. As I said, neurology and neuromuscular, there are some new instructions has been added in neurostimulator implants. So new chart for face-to-face time for brain stimulator analysis and all has been added. Central nervous system assessments and tests. There are 12 codes has been added. In vaccination, we have a new code for influenza viral vaccine. And ophthalmology, there are new codes has been added for ERG, electro retinography, and also in behavior therapy, adaptive behavior services. We have some codes has been added as well. And in cardiac monitoring, some changes happening on the remote monitoring. Let's see in detail. As I said, in ERG, we have some codes added. These are some new codes. ERG with interpretation and report, full field and multifocal field. So it's a very important update to the ophthalmologist. So previously these codes were where we don't have a separate code for this. So, and if there is a pattern ERG which is being performed, you should use with 05090, which is an emerging technology code. But this needs to be separately contacted with the insurance companies if you wanted to perform. Otherwise, if there is an ERG is being performed, with you can use with ERG with interpretation report, full field and multifocal. So previously, whatever the code which we have, 92775, this code has been deleted now. So we have a different set of codes for different kind of fields, multifocal or full field. As I said, then there are some additional codes has been revised. If you can. So 33274 these codes were added before. So those codes, along with those codes, we have to give this additional code for remote monitoring of wireless pulmonary artery pressure sensor. So this code can be used only once for 30 days. So this is again mostly the bigger facilities who are having complex surgeries. They used to build these codes. And apart from that, we have some updates on electrocardiography. This is also not a simple procedure. So this will be electrocardiogram from an implanted brain neurostimulator pulse generator. So if it is implanted, and you can use for up to 30 days. This is one more update. And along with that, there is a code which has been relocated, which is 95829. So intraoperative electrocardiogram has been relocated to this subsection. So neurostimulator programming and analysis. This is some additional. There are some additional codes in neurostimulator programming analysis, 95976 to 95984. So here also, likewise, we have in cardiac. Here also with complex cranial pulse generator, all these things. Whenever a doctor is using this electronic analysis with this neurostimulator pulse generator, you have to use these codes. So simple programming, there are definitions for simple and complex programming. For simple programming, you have to you need at least adjustment of 1 to 3 parameters need to be there. For complex programming, you need to have adjustment of more than 3 parameters. So there are even there was a timing is been given for 983 and 984. So each first 15 minutes face-to-face time you have to use with 95983. For additional each additional 15 minutes you have to use with 95984. So these are high-end facilities who are using this neurostimulator programming and analysis. They can use these codes. And next comes some behavioral changes. Behavioral identification assessments and all. Previously, we don't have codes for this adaptive behavior services. So mostly these codes are not covered with any insurance company. If I'm not wrong, even TICA is not covering behavioral programming. However, if there is a separate special contract with the insurance company, definitely you can utilize these codes. So we have different set of categories for behavioral therapy. So direct face-to-face assessment and direct treatment of patient in group, and also family treatment guidance. So different set of codes are there. So you can use this set of codes when adaptive behavior services were being utilized. So previously these codes we are building with category 2, 3 codes. Now we have a CPT code available for adaptive behavior services. Please make a note. In many facilities which are having a especially these rehabilitation facilities, they are using this adaptive behavior services. And the CMS assessments test, if you can see in psychiatry, neuropsychiatry, we have some changes noted in 2019, especially psychological and neurological testings. We have different set of codes for neurobehavioral status examination. We have 96121, and the testing evaluation services. We have some additional codes 96130, 131, 132, and 133. And the test administration and scoring, we have different set of codes 96136, 137, 138, and 139. Automated testing and results, it's 96146. So most of the psychiatric facilities, they need to check with their clinicians, whether they are doing any of these tests. So some code sets has been updated, and some deletions has been happened in psychiatry as well. So please make sure that please check with your clinicians about this psychological and neuropsychological testings, and code accordingly. Lastly, some updates on the E&M. So it's not related to E&M. It's related to teleconsultation services. Interprofessional telephone services. Sometimes the doctor will perform some interprofessional telephone consultations regarding the care of the patient. With the other clinicians, with other specialists or consultants. So if such things are happening in your facility, please make a note that we have a code set 99446, 447, 448, and 449. These 4 CPT codes are still available. 99451 and 452 are now deleted, but 99446 to 449 is available. So please ensure utilizing these services. Whenever there is an interprofessional telephonic consultation is being happened with other clinician. So these things need to be recorded by the clinician, and the documentation need to prove for what sake the doctor is consulting another clinician, and what are all the discussion happened, and it all needs to be documented along with the time. How much time, whether it is 5 to 10 minutes or 11 to 20 minutes, the doctor has to give starting and start out time. That's it for 2018 to 2019. So we have if I take the touch points, the most importantly the punch biopsy codes. These are very important for us. These punch biopsy codes, and in orthopedic we can see some orthographic codes and some graft course has been added. In cardiology, we have some major changes has been happened in a major section, which is a complex level course. And in gastrostomy, we have guidance course has been added, gastrology. And in 5 series urology, the rhizome therapy, it's one of the important update. And in medicine section, we have this behavioral set of codes, which has been updated, which is also an important update, which we need to highlight in 2019. So let's come to 2019 to 2020. So what kind of journey happened, and what updates we have been noticed in 2019 to 2020. Let's go through the details now. So if you can see the summary changes in 2020, there are 248 codes has been added, 75 codes has been revised, and the deleted codes, 71 codes has been deleted. So when compared to 2019, the updates in 2020 is far lesser than 2019 codes. So which you can observe. You can also note some of the breakdown details for other areas like surgery, radiology, lab and pathology, and medicine. You can see a lot of changes, especially 89 codes has been updated in 2019, laboratory codes. And beyond that, medicine section also we can find a significant increase in new codes. 47 new codes has been added. In surgery, there are more a lot of changes has been happened, in terms of new codes, revisions, and also deletions. Let's go through one by one now. So this is one of the important area which we need to make a note. So in simple repairs, in integumentary section, in terms of repairs, laceration repairs, there was some definition updates for intermediate and complex repair revisions. So if you see in intermediate repair, the highlighted term, which is it includes previously undermining and all will comes under complex repair. Now limited undermining, which is defined as the distance lesser than the maximum width. So this is called as limited undermining. If there is a limited undermining performed, then you should consider it as an intermediate repair. As well as apart from that, there was single layer closure. All these things it is already there. And in complex repair, there are a lot of updates. Requires at least one of the following. Along with intermediate repair, if any of the following is there, then you need to consider it as complex repair. Example, there should be exposure to bone or cartilage, and the tendon exposure, or named neurovascular structure exposure, or debridement of wound edges. Example, traumatic laceration or avulsions. Extensive undermining. You should make a note. Limited undermining will be intermediate repair, but intermediate repair with extensive undermining, which is the distance equal to or maximum than the actual defect, then it is an extensive undermining. And also involving, apart from this extensive undermining, if there is an involving of free margins of helical rim, vernulon border, or nostril rim, or placement of retention sutures, all this constitutes a complex repair. So this is very important update in intermediate and complex repair definitions. So please ensure your general surgeons or your physicians or ortho, whomever the clinicians who are doing these repairs, they need to update their documentation with a clear definition, because sometimes the doctors will do a deeper interventions and they will not document. For intermediate repairs, for example, there might be width will be equal to that. There will be an extensive undermining will be done, but the doctors will not document those extensive undermining. So those things are important. So documentation plays a role because the CPT code varies here. It depends upon the complexity, the code varies and the reimbursement also varies. Let me see. So if you can see in the picture, if you see the wound, if you can see the wound width is 1.5 centimeter. However, the undermining width is 1 centimeter. So if it is lesser than the wound defect width, then it can be considered as for intermediate repair only. So if the wound depth is equal or higher than the actual width of the defect, then it should be considered for complex repair. So this is the important update for intermediate repair and complex repair. If you can see the complex repair example, the wound width defect length is 2 centimeter, and as well as the extensive undermining is also 2 centimeters. So if it is 2 centimeter or if it is more than 2 centimeter, you have to consider it as complex repair. If the wound defect length is lesser than 2 centimeter, then you should consider it for intermediate repair. And along with that, there are some additional terms has been given. So intermediate repair along with repair of exposed bone, cartilage, tendon, or any neurovascular structure, along with the repairment of wound edges. So the documentation clearly says that wound edges has been repaired, and extensive undermining, as I said in the picture, or involvement of free margins of helical ring, vernal border, or nostril ring, and or placement of retention sutures. These and all constitutes the complex repair. And apart from that, there are some additional codes has been updated for tissue graft flaps. So broader classification has been added. So 20926, this is tissue grafts. Other than this code has been deleted before, and there are 5 new codes has been added. So 15769, 15771, 772, and 773, and 774. So these codes are in detail with the different locations. So you can use the codes according to the location and the length of the graph which has been placed. So please make a note of it. This autologous graphs, you need to keep yourself updated with these codes as well. So this some of the changes which has been I'm highlighting again. So deletion of incision and excision subheadings. There are some changes has been happened here. So breast biopsy procedures. There are some changes with breast biopsy procedures. And the chest wall resection codes. There was some update in chest wall resection codes. And the new guidelines for mastectomy. There are a lot of revisions happened in mastectomy. I will show those details as well in future slides. And revised guidelines for breast intersection subsection. So these changes were happened. I will show in the future slides. So apart from this, in musculoskeletal, you can see some two new codes which has been added for needle insertions. Always don't confuse with this acupuncture course. So acupuncture course are something different than these needle insertions. So I have been given the guidelines as well. So needle insertion course, mostly these courses might not be covered under insurance. Check with your insurance companies for the coverage. So most of the insurance companies might not be covering this procedure. And these procedures are alternately known as dry needling or trigger point acupuncture. So these should not be confused with the trigger point procedures, which is a different procedures. These are only needle insertion procedures or otherwise called as dry needling or trigger point acupuncture. So as I said, if there is a trigger point injections are performed, you have to use only 20552 to 20553. So don't use this code along with this 2050560 because it's an exclusion notes. Okay. So even if there is an instructional notes in the parenthesis following 95140 directing users to code 20560 and 20561. If in the manual therapy also, if they are both coded together, there is a bundling. So please cross check about the bundling. And in acupuncture section also, there is an update. So it's a trigger point acupuncture. So if there is an acupuncture services is being performed along with these services, so a parenthetic note also there. So prohibiting reporting acupuncture services, which are 978108811 in conjunction with 20560 and 561. So you do not build this together. So there is in bundling edits will be coming. So please use according to the CC edits for these procedures. So in musculoskeletal, there are some additional codes has been added in terms of manual preparation and insertion and removal of drug delivery devices during orthopedic surgeries. So mostly these are some of the procedures where the doctor used to inject some antibiotics or any other pain medicines, along at the time of operations, during operation, major operations, to reduce the infections and to reduce the pain, to control the pain. So they will inject along with the implants. So whenever they are doing these services, example, the beads, nails, or spaces, they will inject along with some antibiotics or some pain medicines. Those kind of insertions, you have to use this code 207000702 and 704, depending upon the location, whether it is subfacial or intramedullary or intraarticular. Likewise, if there is any removal of these kind of drug delivery devices, you have to use 20701, 703, and 705, depends upon the location. But do not confuse if only removal of drug delivery device is performed without any associated primary procedure. So if there is no primary procedure, then you have to use removal of implant. Okay, if there is any primary procedure is there, then you should utilize 20701, 02, 03, and 05. Otherwise, you have to use 20680 for the removal of implant. Whether it is deep or superficial, you have code 20670. And there are some changes happened in the excision chest wall tumor also. So previously we have two ports, chest wall tumor ports 19260, 271, 272 were there. So these 1 series codes which are in integumentary section has been moved now to 2 series codes, 2160, 602, and 603. So it depends upon the extension of the procedure.
If it is only chest wall tumor, including ribs, we have to go with 601. With the plastic reconstruction, we have to use with 602. If there is a plastic reconstruction along with mediastinal lymphadenopectomy, then you have to use 603. So this is an important update. So previously these codes were in general surgery section. Now these codes were moved to musculoskeletal. There are some cardiovascular updates were there. So there are some codes which are 33010 pericardiocentesis. This course has been deleted. So this course has been deleted with some new update with the guidance. So 33016, 17, 18, and 19, this course has been added. 16 and 17 are related to pericardiocentesis, where image guidance items were performed along with some inhaling catheters are used. You have to use this course. And along with that, there are some age related course also. There's 6 plus years, 33017 we have to use. 33018 is birth through 5 years of age. And pericardial drainage with the insertion of inhaling catheter, there is a separate code you have to use with 33019. So this includes CT guidance as well. So 330171819, there is an important note that you should consider that the catheter must remain in place when the procedure is completed. So if the catheter is placed to aspirate fluid and then removed, then this code should not be used. Okay, so I have been given the update what kind of services is being performed and what codes need to be utilized. Say for example, accessing pericardium, you can use this 33016171819 and ultrasound fluorescence guidance. We can use all these codes for CT guidance. We have a different set of code which is 33019. We have to use only with this code. And if there is an age related also, I have said that less than 5 years, less than 6 years of age, you can use only 33018. And if there is a only drain left in place, you can use 33017, 18, and 19. Along with this, some major changes has been happened in aortic thoracic aorta subsection also. So the existing codes has been deleted, and there was some new codes has been added: 33858, 859, and 871. So these are ascending aortograph with cardiopulmonary bypass. So these are some of the major procedures which are happening in cardiology. Those major facilities which are tertiary cares, which are doing some complex cardiac surgeries, they need to think on these codes. Otherwise, other facilities which are limited to secondary care, they can omit these codes. And there are some add-on codes also there, 34717 and 718. These are which is used in endovascular repair. So these are especially interventional vascular surgery procedures. These codes has been added. So please make a note of it. So endograft placement, endovascular repairs in iliac artery. There are some updates. So previously they were using with 2502540. Now we have a subsection code under CPT category 1. So the same 36417 and 36418, 34717 and 34718. These three codes have been updated. So please make a note of it. And some additional changes has been happened in cardiovascular for arterial exploration procedures. So the code 701 has been revised, and codes 35721, 741, and 761 has been deleted, and 35702 and 703 has been added. So 702 is for exploration not followed by surgical repair, artery upper extremity, and 35703 for lower extremity. So this arterial exploration codes has been updated. So please also make a note. So the earlier codes which are with 721, 741, and 761 has been deleted. So make sure the guidelines has been followed. Whomever is billing this vascular surgeries. So there are a lot of guidelines are there in vascular surgery. So through the access, first degree, second degree, third degree, kind of the catheter invasions and all these things, you should make a note. So depends upon the extremities, we have now different set of codes. And it is one of the now in digestive system, you can see important update. So 46495 and 496 has been revised now. Previously, this THT code, THT is one of the updated procedure which is being done in many facilities for hemorrhoidectomy. So there is an update in hemorrhoidectomy. If it is more than two or more hemorrhoid columns has been dearterized, then only you have to use this 46948. So and also with or without imaging guidance, we have a codes. So 469495 it is for the internal ligation other than rubber band, single hemorrhoid column or group without image guidance, and 46946 is two or more without hemorrhoid guidance. So 46948, 46498 is for two or more hemorrhoid columns, including ultrasound guidance with Vico-Pepsi. So this is an update in THD. So earlier we are using 46946 for this THD. Now we have a code for THD, which is a 469498 or more, and it includes some mucopexy also. So do not code mucopexy as a separate procedure. So and make sure the hemorrhoid columns, it should be more than two columns or two groups. If it is lesser than two columns or two groups, you have to go with accordingly with the 464945 CPT. So whenever you are doing, I think this procedure will be done in day cases. So hemorrhoidal THD kit, the kit will be a separate code, which is greater than 1500 AED for supplies, which can be claimed separately. Please ensure that you are capturing this separately, and do not code ultrasound transceptor for this CPT, because now 46948 includes ultrasound guidance also. So this is also an important update, and more frequently in many facilities this procedure is being performed. And please make sure that update has been happened in 2020. So now you can use these codes appropriately. And there are some digestive system changes as well, where is we have a codes 49013 and 49014 has been added. So these are for peritoneal pelvic packing or pelvic wound packing, the exploration of pelvic wound packing. So these codes again are used along with some of the major procedures, not as a simple procedures. So local exploration and all usually will be included in this procedure. So please do not build local exploration separately. So it includes the packing material, also removing of packing materials also. So please make a note of these additions. And there are some nervous system changes also happened. So two codes were added in spinal function with fluoroscopic and CT guidance. So earlier we don't have a code, separate code for fluoroscopic or CT guidance. Now you can see spinal function, we have two set of codes, 62238 and 3928. 38 is fluoroscopic or CT guidance. Spinal puncture, it's in diagnostic spinal puncture, lumbar puncture. 62329 is for therapeutic puncture. So if there is any intracranial pressure or there, then therapeutically we will do the spinal puncture to release some CSF. So different set of codes for the therapeutic and diagnostic with fluoroscopic or CT guidance. And also there are some revisions happened in 76942 and 77021. So please do not use these codes as an additionally when performing these codes, these procedures. There are some additional changes in nervous system, which is under somatic nerve subsection, where 64450 and 64400 and 64450 were revised to add a phrase and or steroid. Earlier there is no term called steroid. Now they have been updated with steroids. And if you can see the code 64451, so there was an addition highlighted thing, which is an addition as well. Injection anesthesia agent and or steroid now innervating the sacroiliac joint with imaging guidance. And other code 64454, it's for genicular nerve branches. Genicular nerve branches, I will discuss with you that what is this genicular nerve branches and future slides. So if you can see the instruction note again 64454, Injecting genicular nerve branches means it is supralateral, superolateral, and supramedial, inferomedial. So these are the nerve branches for the knee, if I'm not wrong. So if these nerve branches has been injected, then only we need to consider for genicular nerve branches. Otherwise, you have to report with 52 modifier because it's not a complete procedure. So there is a new code to report destruction of genicular nerve branches. So this 64624, as I said in the previous slide, so it needs to three genicular nerve branches need to be destructed. Otherwise, you have to go with only with 52 modifier. So reducer service. So reducer service means you'll be paid only 50% of the revenue. So there is an additional code also been added 64625, which is radio frequency ablation nerves intermitting the sacroiliac joint with image guidance, fluoroscopy or CT. So fluoroscopy or CT cannot be coded separately. So following 64625, there is an parenthetical notes has been added. So uh, user to C code 76999 for radio frequency ablation of nerves innervating the sacroiliac joint. So with ultrasound. So there is no code for ultrasound. So radio frequency ablation with ultrasound, you should not use this code. It should be leading to unlisted code. So if you have separate contracts with the insurance company, you can bill the code. Otherwise, you have to select the nearest code if there is available. So in ophthalmology, we have identified some new codes, in terms of endoscopic photocoagulation. So prior to 2020, these codes, we don't have a separate code for this. We have to build this endoscopic photocoagulation separately. But now in 2020, there is a combination codes is available. Codes are available, especially the ophthalmology institutions or facilities. So you need to make a note of it that whenever you are performing endoscopic cyclophotocoagulation along with the cataract removal, now it should not be a separate code. There is a combination code available, 66987 and 988. So these two codes need to be utilized. So do not bill cyclophotocoagulation separately. And some of the updates you can see in the radiology, in 2020, there are 12 new codes were there and 15 deleted codes are there and 18 revisions happened. So let's go through this. So in 12 revisions, in gastroenterology, you can see some revisions happened. So a complete acute abdomen series, there is some revision happened. So the code specifies two or more views of the abdomen must be included. Examples, supine, erect, or decubitus. So these are 74022 is and revised code, and 74210, the barium contrast exam that includes scout neck photograph and image images. So there are some revisions happened in this 74210 also. Apart from that, we have some revisions happened in 74220, 74221 for esophagus ports also, esophagus X-rays as well. And even in spelling function also, there is some revision happened in the description of this code 74230. And upper gastrointestinal tract, there are some revisions happened 74240, 246, 248. This course has been revised, and along with that, some codes has been deleted. So 74241 has been replaced with 74240. 245 has been replaced with 240 and 248. 74247 has been replaced with 74246. 249 will be replaced with 246 and 248. These are some replacements has been happened along with some deletions. In small intestine section, there are some updates has been happened. Same thing, the code includes multiple serial images along with the scout abdominal radiographics and delayed images. Same revisions happened in the small intestine also. So this is a series of updates happened. Revisions has been happened in the CPT codes, especially in the radiology section of abdomen, small intestine, and digestive system X-rays. So along with that, you can also find some changes in the colon. So from the beginning, acute abdomen series and esophagus, swallowing function, upper GI tract, small intestine, colon, all these areas, there are a lot of revisions has been happened in terms of codes and also some deletions has been happened. And there are some additional changes in myocardial PET coding. So PET studies, as you know, it will be done in institutes where oncology is an preferable area, treatable area. So those areas, we have some new and revised codes are there. So 78459, there is a revision happened, and 78429, it's a new code with concurrent CT imaging as well. 78491, it's a revised. 430, it's a new code. 492, it's a revised code again. 431 is a new code. 432, 433, 434. So from 431 to 434, it's a new codes added here. So multiple study stress and rest. All these codes has been added along with some combined perfusion and metabolic evaluation studies also. There are some new codes available now. So even for AQMBF, like absolute quantitation of myocardial blood flow, we have a code now for rest and physiological stress. So please make a note of these add-on codes, especially the centers where oncology is a preferential location. And in nuclear medicine section, nuclear medicine mostly it's a rare medicine where some of the facilities, bigger facilities, the complex facilities, why utilize this nuclear medicine. So there are some changes in the nuclear medicine also. So inspect, there are some additions 788303132 and 35. So spec whomever is using with the spec or spec cities in nuclear medicine areas, please make a note of it. So spec with concurrent CT, spec with anatomical review for anatomical review, or concurrent CT and localization of the pathology, localization pathology. We have of course separately now, and also you need to ensure that there are some deletions also happen, like liver imaging, bone and joint imaging, brain imaging, CSF imaging, and kidney imaging. The imaging studies which we have with an organ specific has been deleted. Now, if you can see the updated codes, you can see a single area, multiple areas, minimum of two areas. All this has been updated with a single codes now. So add-on codes also there. So you need to make an update. So depends upon the code, you need to give the add-on codes accordingly. The multiple areas or multiple units has been performed more than one day, you have to give the add-on codes here. So this is only again, this is very rare medicine. So the facilities are bigger facilities who have been invested in nuclear medicine, they need to make a note of this update. And please ensure that while building this nuclear medicine codes, you have to build this radio contrast also, the nuclear contrast materials also. So these are some expensive codes, some expensive supplies, which you need to use with build with the HEPX codes. So we have a separate addendum available for these radio pharmaceuticals. So please review that radio pharmaceutical update in DOH addendums, DOH adjudication addendums. So there are some additional radiology updates also there. So as I said before, for lumbar puncture now it is updated with the fluoroscopic CT guidance, and also for some Doppler study we have some update with pre-operative vessel assessment for prior to hemodialysis. So prior to hemodialysis, there will be a Doppler study will be done for arterial and venous flow for hemodialysis access. So when we are doing such procedures, you have to utilize this code. Complete unilateral or bilateral, we have two different set of codes has been added. And in pericardiocentesis and pericardial drainage, as I explained before, so new codes has been added with imaging guidance. So please make a note of it. So previously there is no code for imaging guidance. Now it has been updated. So in 2020 pathology changes, 89 new codes, 5 deleted codes, and 5 revisions has been happened. Again, the 89 new codes, there are the major changes has been happened with PLA codes also. So new therapeutic drug assets, we have some additional of drug codes, drugs included. So adalimumab and infliximab, lacosamide and pesaconazole, adalimumab and vulcanazole. So mostly these high cost drugs, now they have been updated with this drug assays. And apart from that, 103 PLA codes has been added in 2020. So which is a major addition happened in 2020. And beyond the PLA codes, we can see some molecular pathology codes 4 new codes has been added into Tier 1 subsection 812.77.307.308 and 309. Please make a note that molecular pathology subsection codes is not an easy billing codes. Please ensure that if you have a proper contracts with the insurance companies in order to bill these codes. So if you don't have a proper contracts with the insurance companies, you cannot bill these services. These are advanced laboratory medicine codes and might require a special contract with the insurance company, especially for the man. So even there is some additional code for oncology, prostate also 81542. So which is also been added. Okay. In medicine section, there are 47 new codes has been added, 21 deleted codes, and 10 revision codes has been added. So this is one more update in medicine section. So this is one of the frequent procedures which might be done by your physiotherapy. I mean the rehabilitation team. Sometimes it will be done by the general surgery sections also. So now we have a code for biofeedback training the perineal muscles. So which is 90912. Initial 15 minutes we have one code, and each additional 15 minutes we have a additional code 90913. So you need to make a note of it. This is one-to-one physician or QHP contact with the patient. So there should be a patient needs to be there. The physician need to be there. The patient. It's a one-to-one contact. Okay. So this will be done. This will biofeedback training will be done for perineal muscles, anorectal muscles, to ensure if there is any weakness in the muscles and all. The training will be provided. The biofeedback training to be provided to strengthen the muscles surrounding the pelvic area. And there is some update in ophthalmology. So again, we have some codes in ophthalmology. So the 92225, which is an ophthalmoscopy extended with retinal drawing. So with the extended with the retinal drawing. So when there is a retinal drawing is being performed, so you can use this 92235. So if 92235 is an initial code, 26 is in a subsequent code, which are this course earlier has been utilized, has been deleted now. So this course has been now replaced with 92201 and 02. So if you can see 01 and 02, it's an unilateral or bilateral, and along with that there is some updations has been happened with retinal drawing and scleral depression or peripheral retinal diseases. Example: retinal tear, detachment, retinal tumor with interpretation report unilateral and bilateral. So please make a note of it. So this is for the second code 92202 is for drawing of optic nerve or macula. So I have given the graphical illustrations also. So at the top you can see the diagrams for retinal drawing, and the bottom you can see this is for optical nerve or macula. This drawings needs to be updated in your medical record. It needs to be available whenever an auditor is coming and asking for the drawing reports. So please do not record this course when you're billing fundus photography, because these drawings will be completely considered as a duplicate. When we are doing fundus photography, automatically these drawings will be available in fundus photography. So these are bundle codes when we are billing fundus photography. So there is additional code for added for computerized dynamic posturography, or which is posturography, what you call. It's something like a gait training something, and it has 6 sensory organization test, which is for eyes open, eyes closed, visual way, platforms way, eyes closed, platforms way, platform and visuals way. All these 6 tests will be performed. If 6 tests will be performed, 6 conditions will be performed, we can use 92548 for dynamic posturography sensory organization test. And along with that, if you are doing motor control test and adaptation test, you have to use 549. So please make a note the difference. If there is a motor control and adaptation test has been performed, now there was a new code has been added, which is the 92549. So this will be available in most of the rehabilitation facilities would have these kind of machineries, to perform some the rehabilitation services. There are some in medicine section. We have some category 3 codes has been revised. So which has been moved from category 3 code to category 1 code. So myocardial strain imaging, which has been converted to category 1 code with 93356 as an add-on code. So this is one more update which you need to note. So this myocardial strain imaging, again, it will come under nuclear studies. So most of the facilities which has having nuclear medicine, they can make a note of it. And arterial venous studies, as I said before, I have been already highlighted this for hemodialysis access. We have preoperative vessel assessment for the hemodialysis access. We have two set of codes, complete and unilateral. These codes were also updated in 2020 section. And this is a very important update, long-term EEG. This section has been updated, broadly updated with a lot of professional and technical components, to differentiate a professional as well as technical component. So there are two different set of codes has been added, if you can see with video and without video, technical as well as professional. So different set of codes has been added. So almost all 22 codes are added for monitoring subsection. And for setup, we have a code 95700. This is very important update. Everyone who is doing a long-term EEG monitoring, especially the facilities who are having neuro or neuropsychiatry or pediatric neurology, those doctors, those clinicians will utilize this course. Long-term EEG, it's a big update. So in 2020, so always ensure billing this course based on the timings. Because less than 12 hours we have a code, 12 to 26 hours we have a code, greater than 26 hours to 36, greater than 26 hours we have different set of codes are there. And the professional component we have to build separately. Technical component you have to build separately, and with video, without video. All these things you need to consider before building this course. So these codes are make sure that your documentation is updated with all these codes, because as I'm showing here in this table, we have a technical component, we have different set of codes, professional component, we have different set of codes, and also based on the timing and duration, we have different set of codes. So all these codes need to be reflected in your report. If your report is not reflecting with this document details, automatically you might need to you might end up with recovery. So please make sure this medicine section codes, especially this long-term EEG, is a major update. So please make a note of it. And health and behavior assessment. So this is also again a new update. Health and behavior assessment. This course also has been updated in 2020. So the six course has been deleted and the new course has been added. So 96150 to 155 has been replaced with 156 to 171. So health and behavior assessment, again, this is one more important update which happened in 2020 in the medicine section especially. So please make a note of it. This intervention will be depends upon the three types. It is either it is individual or it is a group or family. So based on these three groups, you have different set of codes. For individuals, it's 158 to 159, and for group, it is 164 to 165, and for family, it's 167 to 168. So again, it's family. All these groups, we have different set. It is family with health and behavior intervention. There are other set of codes which are missed here, I think. Okay. So please make sure the timing. So initial timing will be 30 minutes, and each additional will be 15 minutes. So again, as I said, in physiotherapy section, we have an update, important update. There is a code which is 97127. It's a big hit for in 2020. This code is an untimed code in 2018 CPT code section. However, this code has been now moved from untimed code to timed code. So now each 15 minutes we have to utilize this code. There are two set of codes has been added, 97129 and 97130. So these two set of codes has been added. So please make sure on this update on the cognitive function, especially these cognitive function studies are being utilized by occupational therapist. So this occupational therapist previously using this code with as an untimed code, which is 97127. Now it is a time code. So each 15 minutes you have to bill it accordingly. And in 2020, apart from that, there is some revisions happened in bilateral procedure. Earlier in add-on codes, there is no modifier applicable in add-on codes where we are using two quantities. But now in 2020, there is an update in bilateral procedure. So bilateral procedure are performed at the same session should be adding by 50 modifier to the appropriate price code. Now should not be appended. This modifier should not be appended at designated add-on codes. So this is the earlier section. So revise gives an instruction for reporting add-on codes that are performed bilaterally. Previously, this instruction for reporting add-on procedures when report bilaterally varied throughout the code set, whereby some code add-on codes were reported twice, while others were reported with modifier 50 appended. So this instruction for reporting add-on procedures were performed bilaterally has been standardized to indicate that add-on code should be reported twice instead of reporting modifier 50. So previously we are using modifier 50 for bilateral add-on codes. Now this modifier 50 should not be appended for add-on codes. You have to utilize with quantities. So moving forward, we will see an update from 2020 to 2021. So in 2021, we have around we have new codes. We have 206 new codes are there, and the revised codes 69 codes are there, and deleted codes 54 codes are there. So I have been bifurcated according to the departments. Surgery section 11 codes are being new, 29 codes revised, and 7 codes has been deleted. And the major update has been happened in lab and pathology, which is 118 codes, out of which majorly happened in PLA. And in medicine section also there are some updates. 18 codes has been added newly. So let's go through 2021 updates now. So if you can see in 2021 there are a lot of revisions happened in integumentary section, that is general surgery, where the CPT codes descriptions has been revised. I have been highlighted the revision in the separate column for each and every CPT code. So whatever it is there, earlier there was a process in, let's take an example, 11970. Earlier there is a process which was there. Now it is being replaced with an implant. So like that, there are a lot of changes which has been revised, in 2021 section. So almost most of the rest section, you can see a lot of revisions happened in terms of description, code descriptions and all. So, and also you need to make a note that, the 19325 is been converted into parent code now, and the 19367 and 369 has been moved to child codes. Again, there is some deletions has been happened in this deletion has been happened in 19324. This memoplastic code has been deleted in 2020. However, this course has been now replaced in 2021 subsection with the grafting. With the grafting codes, I hope everyone has been. I have been updated with some graft codes, and while we are discussing 2020, so now we have to build with these grafting codes in 2021. And breast reconstruction code, this code has been deleted 19366 in 2021. And coming to musculoskeletal section, this is again an important update. Mostly the arthroscopic areas. So we are using these codes, arthroscopic removal of loose bodies. So when there was an update, now whenever you are billing these loose bodies, you need to ensure this update has been given to the doctors as well. So when you need to bill loose body, arthroscopic removal of loose bodies, when the lesion size is equal to or larger than the diameter of the arthroscopic cannula, so then only you can utilize, or can only be removed through a cannula larger than that used for the specific procedure. So the doctor has to remove that cannula and they need to use a new cannula which is larger than the previous cannula to remove this loose bodies or foreign bodies, or there should be a separate incision need to be there to remove these loose bodies, or through a portal that has been enlarged to allow removal of these loose or foreign bodies. So the complexity of the procedure has been increased in order to build these loose or foreign bodies. So when a loose or foreign bodies, when they are removed with usual normal arthroscopic cannulas, these ports cannot be built separately. So there might be instances your doctors were usually doing such procedures, by adding some new cannulas and all. But there might be they are not documenting these cannulas separately in their operating notes. In such instances, what you have to do, you have to give an update to your doctors that this is an important update which you need to highlight to your doctors that when you want in order to build these loose bodies or foreign bodies, these documentation are mandatory and it needs to be available in your operating notes. Again, one more update in arthroscopic shoulder, surgical debridement, limited or extensive. So in limited or extensive, we have an update that if the debridement is being done in one or two discrete structures, then you have to build limited one. So the discrete structures also they have been updated like a humeral bone, humeral articular cartilage, iliac bone, linear articular cartilage, biceps tendon, biceps anchor complex, labrum articular capsule, articular side of the rotator capsule. So dorsal side rotator cuff, subabdominal bursa, foreign body, all these areas. If it is limited, so one or two areas, if it is performed, this orthopedic debridement has been performed in two discrete areas, two discrete structures, then you can go with limited. If more than two, that means if it three or more has been performed, then you can build extensive debridement. So this code is very important again. Likewise, loose bodies, this debridement code also is very important, usually being performed in shoulder surgeries. So please update your doctors with this update. So some of the cardiovascular, there are some updates happened. Uh, 30468, this is a removal of repair of nasal wall collapse. Excuse me, just 2 minutes. Sorry. So there was a new code in cardiovascular 30468, repair of nasal wall collapse with subcutaneous or submucosal lateral wall implant. This is a new code which has been added, and there was a deletion happened in 32405 biopsy of lung mediastinum percutaneous needle. This is a deleted code. Instead of that, there was a new code has been added. Core needle biopsy lung mediastinum percutaneous, including image guidance. So a lot of updates are happening in 2019, 2020, and 2021 by including this image guidance. This image guidance is an important topic. Where we have a leverage to build these codes separately in 2018 or before. Now there was a technology advancement was there, so all these codes are being merged together with the actual CPT codes. So please make a note when there is an including image guidance is documented. Do not build any image guidance separately from the actual code. And there are some additional codes in cardiovascular section again. 33741, 745, and 746. So which are for atrial septostomy and transcatheter intracardiac stent, which has an add-on code with each additional stent location. So these codes has been updated. So please make a note of it. So these are performed in tertiary care centers. So please make a note of it. So there are some two codes has been added for insertion and removal of ventricular assist device. So 33995 and 997. So insertion and removal. These codes has been added. These are new codes. So again, these are percutaneous codes. So please make a note that removal should be at separate and distinct session from insertion. So if it is happening on the same session, then it should not be coded separately. Okay. And there are some codes has been revised. I have been added the revisions with an underlying in each and every CPT code. So 3399, 099, 1992, and 993. So there are some additional expansions has been given with anatomical locations and all. So please make a note of it. And in gender urinary section again, there was an additional code for ablation of prostate. As you can notice in 2019, 2020, we have laser therapy in 2019. So in 2021, we have a code for HIFO, high intensity focused ultrasound, which is being done under ultrasound guidance. So this code has been added now. So 55880. So earlier we are using this with unlisted code. Now we have a code for this. And also in cervix uteri, there is an add-on code, computer aided mapping. So during colposcopy, this computer aided mapping of cervix uteri is performed. You can build this code separately. So this is an add-on code again. So use in conjunction with other code 57465. Okay, along with 57420. So this is an add-on code. So don't build it separately. And there are some codes has been deleted like vaginectomy and vaginal hysterectomy with closed cystospexy. So these codes has been deleted as well in genital urinary section. So in ENT, this is again an important update. So nasopharyngoscopy, surgical with dilation of eustachian tubes. So earlier we don't have a separate code for this. It's very difficult for us to use this code. So we are it is going to unlisted codes and all. So now we have an opportunity to build nasopharyngoscopy with the dilation of eustachian tube. Either it is unilateral or bilateral, you have a different set of codes. So ETBD. So now we have an update. So please make a note of it, and it can be built whenever it is performed. So you can also note in a exclusory note, in the parentheses, 69706 to indicate should not be reported with nasal endoscopy procedures. So whenever you are doing an nasal endoscopy procedure or nasopharyngoscopy, these codes cannot be built together. So it's in bundle code, so don't report it separately. So we need to educate the clinician accordingly. And there are some new codes also. So nasal implant repair, which is a new code which has been updated in 2021, 30468. So whenever the doctors are performing any absorbable nasal implant repairs, so you can use this code. In 2021, there are some radiology section updates also there. 2 codes has been added and 5 deleted codes and 6 revision codes are there. So let's see the revisions. So there is new code which is CT thorax loaders for lung cancer screening. So again, this is a screening code. So please ensure that whether it is covered under insurance or not. You need to check with your payers. So there are some kind of notes has been given, in 71271. So please do not report with whenever you are doing with 71250, 71260, This is CT thorax if I am not wrong. So when CT thorax is performed, don't build the screening codes. Likewise, this code is bundled in breast test procedures also. And there are some revisions happened in ophthalmic ultrasound diagnostic B scan. So earlier there is no unilateral bilateral. So now the term has been updated. So this revision has been happened. Also in CT thorax, now they have been added a diagnostic in that, because since there is an additional new code for screening, so they updated with diagnostic in 71250 So as I said, the screening, when you are doing screening and diagnostic, please do not do screening. It is included. Okay, and there is a revision happened in antegrade urography. So they removed the words like pilostogram and nephrostogram or lupogram in 74425. And apart from that, there is a code has been deleted, which is 76970. 76970 is an ultrasound follow-up. This code has been now deleted. It is moved from 2021 chapter. So there are some a new code also added for 76145, which is medical physics dose evaluation for radiation exposure. So whomever is again oncology, it's mostly used in oncology. So whenever this medical physics dose evaluation is been done for radiation exposure, you can use this code. And there are some pathology updates to 2021. 180 new codes has been added, 8 codes has been deleted, and 10 revision codes has been updated. So out of which the majority updates, as usual, it's happening at the PLA. But apart from that, there are some therapeutic drug assay codes has been updated with some additional drugs. You can note that there are some over-the-counter medication has been updated here, and also 16 Tier 2 molecular pathology codes has been moved to Tier 1 codes. So this is an update again, and some gene expression codes has been updated. 8151, 3514, 529, and 546, which are with the different set of panels for bacterial vaginosis and vaginitis, and cutaneous melanoma, and also for oncology thyroid. There is a gene expression has been added now in molecular pathology sections. And also in 2021, you can find an update on COVID-19 CPT codes also. So which is nucleic acid PCR test, 87635. This code is now updated with a revised price in mandatory tariff. So please make sure that all your systems were updated with this updated code. I think it is effective from October 2023, if I'm not wrong. And there are some combination codes also has been updated, 87636 and 637 for influenza A and B, and also with RSV. And antigen testing, along with the antigen testing, antibody also, I think this fluorescent assay testing has been updated. So all these testings in COVID-19 has been updated. So apart from that, the immunoassay testing course also is available now. So please make a note of it. So antibody code also now it is available in 2021, 86769. And in chemistry section, some alcohol, any specimen expect urine. So this analysis has been updated. Estradiol, this is one more important test, where most of the gynecologists used to ask estradiol free. Now we have a separate code for estradiol free direct measurement. So this code is being updated. So this COVID code already formed. And in gynecology, this chorionic gonadotropin stimulation panel, they added this. There is a total has been added in this total. So this update, this is a revision. And as I said, there is a major update in PLA codes in 2021 as well. So in 2021, there are some medicine changes. In medicine changes, there are 18 new codes has been added, and 9 deleted codes and 4 revision codes has been added. So in 18 deletion, so the updates are as follows. In ophthalmology section, you can see imaging of retina for detection or monitoring of disease, point of care testing, analysis report, unilateral or bilateral. So this is point of testing. So we have a course earlier with a different set of codes. Instead of point of care testing, there are remote reporting and all these codes are there. Now there is a code additional for point of care testing 92229 also there. So also then there is a revision happened in the CPT code. So revision CPT 92227 to make it as a parental, and these additional codes 9228 and 2229 are as child codes. And there is major update in VEMP, visual evoked myogenic potential codes. This update has been happened. So 95117 to 92519. So this course has been added now. So this is very important. You need to inform your ENT clinicians. And previously, the auditory potentials also, this course has been, there are some 2 courses has been deleted, and they was revised with 4 more courses. 92585 and 586 has been deleted, and it has been added with different category codes like 92650 to 653 with different descriptions. So this is an important updation in auditory potential as well as vestibular myogenic potentials. If any facilities who are having an importance of hearing hearing aids or ENT with complex kind of diagnostics. So please make a note of it. These two sections has been updated now. So you can utilize the codes based on the service which is rendered to the patient. And external EEG, there are some updates in external EEG. Again, it's based on earlier we have a codes mostly for long-term continuous recorders for more than 48 hours and up to 7 days, or greater than 7 days and up to 15 days. Before it was until 48 hours only. Now it has been extended to 48 hours to 7 days and 7 days to 15 days, 7 days to 15 days. So these changes has been happened. So this is very important update in ECG, external EEG. So this external EEG recording again, we need to consider the days, and also these days are important now. So we have long-term course are available with the number of days, 48 to 7 days and 7 days and above days. Again, recording, scanning, and interpretation, we have different set of codes in this category. So please utilize the codes accordingly. So apart from that, and last and least, there are some updates in revisions happened in 96417. This is exercise test for bronchospasm. So there is a description change in exercise test for bronchospasm. So this revision is already available in 2021 CPT codes. And the 94619, this is again a new code. Exercise test for bronchospasm include pre and post spirometry and pulse oximetry without ECG. So this is a new code addition in 2021. So please make a note of this code as well in 2021. So apart from this, there are some major changes happened in 2021, where in ENM, especially in ENM. So in ENM also there is this update has been happened in outpatient ENM codes. So effective March, DOH is planning to revise the ENM section codes with 2021's ENM codes. So please make sure that you are updated with 2021 ENM codes. So in future, you will not find 99201. So clinicians will not give any importance to ROIs or physical examination. So ENM will be coded based on the medical necessity as well as the time the patient is being monitored. So these updates are important, and everyone should follow according to the guidelines published. So that's it. I think that's it from my end. So thank you for giving me an opportunity. If there is any questions or concerns, you are happy to address.
Hello.
Hello?
Hello, Dr. Lavanya here. Can we get these documents through mail? No, the modules which you have shown, right, for the training. Can we get that modules through mail? I don't have that group. I'm not added in that. Okay. Okay, great. Okay, great. Thank you.
Yeah. Sir. No doubts. Thank you.
Excuse me. Hello. I would like to ask one question. What is the update that we are following into 2021 for modifier 50? Now, like, are we reporting 50 modified to the primary code, or are we giving to use additional codes? What is that? I need the clarity that we are following in 2021.
Modify 50, you have to code with quantity 1 and 50 modifier tag to that as an observation. And the price for this CPT should be 150%.
Okay, thank you.
Okay.
Hi. Hi, Kiran. Thank you for the session. It was very informative. Actually, I want to clarify something regarding modifiers, like 52 modifiers. For example, 52 modifiers. It should be for reduced services of ENM, no? For the follow-up period. Am I right?
See, 52 modifier is, for extended follow-up period. So
Yes.
whenever a patient is coming with the same complaint after 7 days, I mean after 8 to 14 days, between 8 to 14 days, if the patient is coming with the same complaint, which is happened in 1 to 7 days, then you have to
Yes.
bill this ENM, between this 8 to 14 days with 52 modifier. So if you are tagging this 52 modifier, you will get only 50% reimbursement.
Yes, that I understood, but I have a doubt. Normally, we are giving for initially new patient ENM. After
Okay.
7 days, it should be established patient ENM, right?
Yes.
So
Yes.
that 50% from we are deducting from established code, no?
Exactly.
Price. Exactly. Okay. Okay.
Hello.
Then I have one more query regarding modifier 50.
Please.
Actually, normally in the CPT, it should be for bilateral procedure like right and left, right? So now it should be only for bilateral surgical procedure only, no?
Yeah, whatever which is listed by DOH, you have to apply 50 modifier only for those services.
Okay. And all.
Hello.
Yes. Thank you.
Thank you.
Hello. Hello.
Yes.
Use their away. Sir, I need the
Hi, sir. This is Giran.
see you.
Hi,
Okay,
Kiran. This is Navin.
I just want to add in Telegram. That's it. Okay, thank you.
Hi, Kiran. This is Navin. Can you hear me?
Hi, this is Priyadashini. Hello, for this 24 modifier, as per our guidelines, it should be for post-operative care, right? But the recent update from Daman, they are telling for all visit we can use, like after the extension E&M code, we can use it for new visit. Like it's correct, right? Yeah. Okay. Thank you. Please share that
Hello, Kiran.
Telegram.
This is Navin.
Can you share the Telegram link? Okay. Thank you. Thank you very much.
Kiran, can you hear me?
Yeah, I can hear you.
Hello. Yes, Kiran, this is Navin. So I have one doubt in coding actually. There is a see, patient is having incision and drainage deep, and debridement subcutaneous has been done in the same site. What would be the? Can we code together?
No, debridement will be inclusive in incision and drainage. You cannot bill it separately.
No, Kiran. See, my question is, it is in deep. So if it is deep, also we should not code separately because the deep is coming
If there
like
is
too
a deep,
serious.
see if they insist, if there is a deep debridement has been done along with incisions, can someone be muted? If, okay.
Yes, Kiran. Actually,
See, Naveen, there are depends upon the complexity. See, when the debridement is done deeper into the tissues, and if it is extending, you can build a complex IND instead of simple IND.
No, Kiran. Actually, incision drainage is a deep, and subcutaneous debridement is done on the subcutaneous, but the same site. Yep.
So usually, that's what subcutaneous debridement, normal debridement, which is inclusive in IND. So don't build it separately. Okay.
Okay. Only the incisional drainage is enough.
You can build
To
it.
code.
Yeah, complex IND you can build.
Okay, okay. Thank you so much.
Yes, Fatima. I have seen raise hands from Leo Kamo.
Hello. Yes, sir. I just want to. Hello.
Yep.
Yeah.
Leo, go ahead.
I just want to clarify regarding the modifiers. And like the implementation for HAAD for Abu Dhabi, and also like where can we get the circular or link for that one? And at the same time, are there any updates that DHA will follow the modifier implementation as well? Thank you.
Recently, there was an update from the MAN on they have given training across Abu Dhabi and aligned clients. So those presentation has been shared by the MAN in their through the emails also. So if you don't receive, then you need to check with your the person who is responsible in receiving emails, and you can get from them. So, Sheikh, can we also update this circular in our local chapter meeting? Get it from their get it from their senior management. Yeah.
Okay. Thank you.
Okay.
Hi, sir. I have one doubt regarding this modifier 52. If patient came on 8th visit, the same complaint patient has and also unrelated complaint. And IV infusion were provided to unrelated complaint, but there was no prescription is given. But prescription is given to the first complaint. The first visit, the patient has one complaint. The prescription is given to that complaint, but there is an alternative treatment given to the unrelated complaint. So should I assign modifier 24 or 52?
If the reason for visit is unrelated and related complaint, you can choose either of those as a safe complaint. So you can build unrelated complaint as a new visit, and you can tag it with the modifier 24.
24.
Yeah.
Okay.
Make sure that one has a principal diagnosis, because if more than one condition is there, you can choose either of those as a principal diagnosis.
Okay. And also, I have doubt on this IND and suture removal. This clinic, we can build this suturing and IND.
Suture removal is already included in suture repair, right? So we cannot build separately.
No, I mean the patient came for IND. So as a clinic, we can build IND procedure also. Is it billable? I mean, whenever I build that one, we are getting this MNEC rejection actually, MNEC 004. But even there is code and reports, but still we are getting
now there
rejection.
is a modifier 25 is available. So you need to ensure that it is a distinct ENM has been performed, because if the patient is coming only for IND and no other diagnosis or management has been performed, then only IND need to be built. The patient is having a different complaint.
Pardon?
Okay, I can bill that E&M, but it will be in zero payment, and
It
I
should
have
be-
to assign the
yeah,
modifier.
You can bill with 0, and also you can bill an E&M if it is a distinctly identifiable service. That means
Okay.
it should not be related with IND.
Okay, but if it is related, I can bill E&M with zero payment, and I have to assign.
Yes, 0 you can bill.
Okay, and what about this 97602? I can get any example related this 97602? I have always doubt on this one. In which scenario actually this one is coding?
97602. 97602
Yeah.
is
Active
dietitian
wound
is
management.
active
I mean,
management.
at least an idea.
1 second. 97602.
Yeah.
Can you confirm the code again?
I think 97602, right? One
Removal
second.
of devitalized. You mean to say removal of devitalized tissue?
Yeah, that one. Active
this
wound
can be-
management area, that code.
Yeah, this can be built whenever there was an non-selective debridement is done, without any anesthesia, you can build this code.
But can we build that one in the first visit with E&M, or the same scenario is applicable?
No, the patient is coming only for the debridement, then you cannot build an ENM.
No, I mean there is an alternative complaint also there. There is chronic
Definitely you
condition
can build.
patient has,
Then you can build it with the 25 modifier, no problem.
Okay. But recently only this modifier is applied, right? So is it applicable only for the February claims? Because the circular was came on February, so I'm still sending the January claim. So I have to apply this modifier in January claims,
The
or
25 modifier, I think it is updated earlier. Only there are 3 additional modifiers has been added recently: 52, 24, and 50. 25
I
is
mean
there.
24 when it was came. Actually, I did not receive any circular regarding. Means recently I have started in the coding.
That you need to check in DOH dear. It is updated. I think it's from September or October.
I mean, in Shafafia under prices, I have to check, right?
Yeah.
Okay. So recently, which one it was added? This reduced service 52.
52 is added from recently.
Recently. Okay, sir. Thank you so much.
Hi, dear.
Yes.
Actually, I have query about infusion charges. Normally, if it's billed with the ENM, we have showing NCC edits. It will included in the ENM like that. So it is billable with the infusion charges normally.
What
ENM.
edits is showing?
Actually, no. In the infusion charges like 9636Y, 96374, when this build with the ENM codes, there is NCC edits.
What edits you are getting? 0, 1, or 9?
Like it can be overridden with the modifiers like that. That hint we will get.
See, if it is 0, you cannot bill. If it is 1 and 9, you can bill it separately.
Sorry, I didn't get you. You are saying about edit?
In NCCA edits, we have 3 modifiers: 0,
Yes.
1, and 9. If it is 0, it's a bundle service. If it is 1, you can bill it separately along with 59 modifier. Of course, we are not using 59 modifier here. And if it is 9, it's so if it is not applicable, means you can bill it together.
Okay, but there is something, no? If it can bill if there is any unrelated diagnosis or something, no? Otherwise, we can reject that ENM, no?
No, nothing like that. See, the injection services will be given only based after the evaluation. They are just notice. Okay, it's not a procedure. It's a medical service.
Okay, thank you.
Hello, good afternoon, Kiran. Thank you so much for this wonderful session. My name is Adra. I have a doubt about the psychological testing and evaluation code 96132. Hello? Can you hear me?
Tell me.
Yeah, okay. So this code description says service can be done by the physician or other qualified healthcare professional. So if this code can be built under psychologist, DOH is accepting that one, or?
Yeah, it can be built. It can be built by psychologist. If it is under the scope of practice, it can be built.
Thank you.
No, no. For psychologists, there are some updated scope of practice which has been given by defined by DOH. They need to check the scope of practice in DOH for psychologists, and if these tests are there in the scope of practice, they need to send the privileges for the psychologist to the MAR, so they will update their system and then they can perform it.
Okay. This will not be rejected with code 10 is the usual deniers for this type of code.
Code 10 is mostly, you need to update the privileges to the DMAR. Then only you can.
Okay. Okay. Thank you so much.
Okay. And the referring doctor should be psychiatrist and rendering doctor should be psychologist.
Okay.
Hi, good afternoon.
Good afternoon.
Hi, my name is Geetu. I have a question to Kiran sir. Actually, sir, we have two new codes as per 2021 code set, 81513 and 8154. Sir, can you please explain how we can report this 81513 and 81514?
81513 and 514. This is for RNA markers for bacterial vaginosis, right?
Yes, yes.
So we have different set of codes here, for bacterial vaginosis and vaginitis, and only for vaginosis. So you have to, based on the doctor's order, you have to bill with these codes. If the doctor is requesting only for vaginosis related to specific type of bacteria, you can see in the description also. For vaginosis, we have Atopium vaginae, Gardnerella, and Lactobacillus. If it is only for this bacteria, then you can use with this 81513. Otherwise, if there is an extended bacteria like Megasphere or any other bacteria, you can use 81514. But these two conditions need to be there: vaginosis and vaginitis. Then only you can fill 81514. And again, these are some advanced procedures. Before doing these procedures, please cross check with your insurance whether these codes are added in your contract or not.
Okay, so you mean to say that to report this 81513 and 514, we need a special contract?
Yes, because some insurance might need it. No, that's why I'm asking. Especially for the MAR, they usually, for these markers and all, they need special contracts. These are new codes as well.
Okay. Sir, how about the reporting? It needs a extended reporting while comparative to the other.
It will be done by your laboratory team, right? These are RNA markers, so they will provide the reports according to that.
Okay. Sir, I have one.
Yeah, tell me.
Sir, how about this demand basic? We have GP as well as SP on the same day for the same chief complaint. So how it will be the reporting? Is there any difference in the reporting of chief complaint? This GP and SP should have the same chief complaint or it should be different? Is there any update of this one, doctor?
For the MAN, it's a gatekeeper policy. So always you need to visit the GP, in order to see any specialist or consultant. So for initial complaint, you will not need it in consultation. If it is a direct referral. Why a GP is doing a complete evaluation and sending the patient to an SP? The patient can be referred directly from GP to SP. Here the GP visit will be zero charges and SP visit will be the normal ENM.
Okay. How about the chief complaint, sir?
The initial ENM you are not billing, right? Either you will bill with the lower ENM or you will be referring the patient to other doctor. It will be zero charges.
Okay. Understood, sir. Sir, I have one more doubt. We have a scope of practice available for podiatrists now.
Yeah.
But recently we are receiving claim 16 rejection for reporting this levels of ENM. So how we can handle this one, sir?
We need to raise to PRD, raise it to PRD and update with this privileges to them, the scope of practice to them, and they need to update their system. Otherwise, you will get with this claim.
Okay, noted, sir. Thank you so much.
Okay.
Hi, Kiran.
Yeah, hi.
Thank you for the session. And I have one doubt regarding Modify 52. As per DOH circular, is that applicable only for E&M or can be used for other procedures?
Modifier 52 right now, what we are using for the consultation services, you know. But if there is any procedure which you are thinking that, you know, it's a reduced service, you can also use that one, but you will get only 50% payment for that.
Okay. Okay. For example, you, as per your presentation, one nervous system code that was.
Exactly. This is based on US guidelines. You know, in US guidelines, if there is modified 50, if the service is performed partially, you have to use 52 modifier. So, but you know, in local guidelines, you know, these CPT modifiers will be very varied. You know, so right now, what DOH has been given to us, DOH has given to us the 52 modifier should be used for the consultation. You know, reduced E&M service for the extended follow up.
Only for consultation or
but you can also utilize this 52 modifier for this service also to prove that, you know, this service is performed partially.
Okay. So, for example, that injection of anesthetic agents 64454 code. There is okay. So there is three genicular nerve branches are there. So if they are using one branch only, how will be the cost? I mean, 1/3 or
it should be reduced modifier.
1/3 or right?
Only if it is 3 is performed, then only you can bill a complete set.
Complete
Otherwise,
set.
you cannot bill this code. Yes.
Otherwise, we have to use modify 52, right?
Yes.
So the how I mean the cost will be how will be the cost like if they are using only two branches, the cost will be deducted by 2/3, right? I mean if it is 100,
only 50% you can claim with 52 modifier.
Okay, only 50%. Okay. So one more doubt, like for DOH, I mean, if there is day case procedures, there is NCC like if they are billing what injection code and procedure code. So is that included in procedure code or we like you get you get my point? We cannot bill separately, right?
The injection codes are always inclusive, right?
Inclusive. So we cannot bill injection code separately.
No, we cannot bill it separately.
Okay. Thank you, Kiran.
Hi, Kiran. Thanks for the presentation. I think some of us need to attend other meeting, but could you please share the attendance link form so others who don't have any other doubts or question can just leave the meeting. Thank you.
Hi, sir. I have one more doubt regarding this addendum 35. Is it still valid or is it retired? I mean, in that last presentation in the month, it was mentioned that addendum 35 is retired. Something, one sentence was mentioned there. Still, I can refer that one. Okay. Okay, because usually for the NAS insurance, I'm getting rejection whenever there is injection. Even it's not within 14 days. It is always saying that price bundle rejection for the E&M. So is this 96374 or 96365 is bundled with any procedure? How I will identify that is this bundle procedure or no? I mean, before I was. Okay. Okay, because usually I was checking with this addendum 35, there was listed of minor procedure, right? So, but now it is retired, right? Okay. Thank you so much, sir.
Good afternoon to all. Sorry. Yeah. So can I ask the question? Yeah, sure. So thanks a lot, Kiran, for your in-depth and detailed presentation today. We really appreciate it. And small request to Sheikh also. So if you could please arrange for another session related to this 2021 ENM codes only, because I know, okay, actually we had a session related to the code changes, but related to the EMR documentation requirement for UA, it would be helpful for us. And I have two doubts actually. One is related to the ophthalmology. So Kiran mentioned that there was some bundle codes related to the fundus photography and the retinal drawing. So can you please, Kiran, can you please update on us on that?
Yeah, what is your question? What is your question?
Ophthalmology, related to ophthalmology, there was some bundling you were mentioning in your presentation related to the ophthalmology retinal drawing and fundus photography or something like that. Can you please repeat it?
This is happened in 2020, if I'm not wrong.
Yes, 2021. Yes, 2020.
So whenever you are using this 92201 and 92202,
02. Okay.
These two codes, this ophthalmology extended with the retinal drawing and optic nerve drawing.
Okay.
So when you are doing along with these services, when you are doing fundus photography, usually this fundus photography will show these retinal drawings or optic nerve. If there is no fundus photography in your clinic, if the doctor is drawing based on his examination, you can build them separate. But if you are having fundus photography and if you are doing fundus photography, you cannot build this. Yeah.
Okay, 92285 is bundled with this 92201, right?
92250, 92201 and 02 is bundled with fundus photography.
Okay, fine. Okay, fine. And my next doubt is related to the DOH published list for the modifier 50 usage. It doesn't have these X-ray codes in it, like knee X-rays. So as per coding guidelines, we have to append this 50 modifier for bilateral procedures, right? So, but
Whatever
DOH list.
whatever listed in DOH, for 50 modifier, those CPT codes only applicable.
Okay,
Remaining ones are not.
so for the remaining ones, we will continue with quantity 2.
Quantity 2, yes.
Okay, great. Thank you.
Yeah.